point where you hear intermittent sounds and where you hear constant sounds. There are some EKG findings that may be seen in tamponade. Most patients have sinus tachycardia. You may also see low voltage of the QRS complexes. The EKG sees less electricity due to the effusion around the heart, and therefore instead of having a big, tall QRS complex, you may have a small QRS complex. That's called low voltage. And then finally, some patients have a heart that is swinging inside the pericardial effusion. They will develop an EKG finding called electrical alternans. This is when some QRS complexes are bigger and others are smaller in an alternating pattern. Basically, the heart is swinging inside the effusion with each heartbeat, and that creates electrical alternans. In another video, I talk about venous pressure tracings and all the normal findings, including the A wave and the V wave. You should be aware that there are two classic venous pressure tracings seen in tamponade. They are called a prominent X descent and a blunted Y descent. The X descent is right here. It's the fall in pressure after the A wave caused by relaxation of the right atrium. The Y descent is right here. It's the fall in pressure after the V wave caused by filling of the right ventricle from the right atrium. Basically, blood is leaving the right atrium for the right ventricle, and that causes the pressure to fall. In tamponade, there is a prominent X descent, and this is caused by a change in the fluid surrounding the heart. To understand this, let's draw a right ventricular cavity, and we have the tricuspid valve here, and above the right ventricle, we have the right atrium. In tamponade, there is a fluid collection surrounding both chambers. When the right ventricle contracts, these walls move inward. This allows some of the fluid surrounding the right atrium to move down in the pericardial cavity. This makes it very easy for the right atrium to relax, and thus there is very vigorous relaxation of the right atrium. Remember, relaxation of the right atrium is what causes the X descent. So instead of getting a normal gentle fall in pressure like you would see in the right atrium for a normal X descent, you get a much deeper and more prominent X descent in patients with tamponade. And I've summarized these points here. There's a deep fall in RA pressure during right ventricular contraction in systole. Remember, systole occurs between the C wave and the V wave. That's when the right ventricle is contracting, and you get a very deep and prominent X descent in patients with tamponade. The other finding in tamponade is a blunting of the Y descent. So the Y descent, shown right here on the normal tracing, is caused by blood leaving the right atrium for the right ventricle. And there's poor RV filling in diastole in patients with tamponade, and therefore the Y descent is blunted. So what you see in patients with tamponade is something I'm going to show on the bottom of the screen here. You've got a very prominent X descent here and a very flat or blunted Y descent. Besides all those findings in the venous pressure tracing, there is another classic finding of tamponade that you can see when you measure the pressure in all the chambers in the heart. This finding is called equalization of pressures. This is what you see when the cardiac chambers cannot relax. What you see is that the pressure in the right atrium, right ventricle, left atrium, left ventricle fall, but then abruptly stop at some high level. You see this finding, equalization of pressures, in both tamponade and in pericardial constriction, which we'll talk about in a minute. So let's take a look at what I've drawn in this table on the screen here. So a normal right atrial mean pressure is about 5. A normal right ventricular pressure is 20/5. And a normal pulmonary capillary wedge pressure, which is a marker of left atrial pressure, is about 10. In tamponade, what you see is that, first of all the pressures are high, and that should make sense to you. This patient's heart is surrounded by fluid, so all the pressures are high. But you also see something else. There is equalization of pressures. The mean RA pressure is the same as the RV diastolic pressure and the wedge pressure. This is not a normal finding. This is called equalization of pressures, and this is what occurs in tamponade. To understand this, let's imagine we've got the right atrium here, and it is relaxing, so the walls are moving outward in this direction, and the pressure in the right atrium starts to fall. But as soon as it gets to 20, it can't fall any further in tamponade. Why is that? That's because there's fluid surrounding the right atrium, and the pressure of that fluid is 20, so the right atrium can never get below that pressure. And the same thing is also true in the left atrium and in the left ventricle during diastole. The bottom pressures for all those chambers are being dictated by the pressure in the pericardial sac, not by what's going on with the myocardium and relaxation. Our last pericardial disease is constrictive pericarditis. In this condition, there is a fibrous calcified scar in the pericardium, and as a result, the pericardium loses its elasticity. It becomes stiff, thickened, and sticky. And this can result from many pericardial disease processes. So patients who have had pericarditis once can later develop constrictive pericarditis. Patients who have had chest radiation to treat malignancy can develop constrictive pericarditis. And any patient that's had heart surgery and had their pericardium damaged during the operation can also develop constrictive pericarditis. Here's an example of an X-ray from a patient with constrictive pericarditis. Note that there are these white lines in the pericardium surrounding the heart. That is evidence of calcification of the pericardium. And that's one of the hallmarks of constrictive pericarditis. The main complaint that patients with constrictive pericarditis have is dyspnea, and you should be aware that on exam, right heart failure symptoms predominate. The right ventricle is the most impacted by that calcified pericardium surrounding the heart. So these patients often have signs and symptoms of right heart failure. This includes elevated jugular venous pressure, lower extremity edema, and even congestion of the liver that can sometimes lead to cirrhosis. When the liver becomes cirrhotic from heart failure, that's called nutmeg liver, and this is a picture of a nutmeg to remind you of that on the screen. And one thing you need to be aware of is sometimes patients with constrictive pericarditis look like patients with cirrhosis. They can have a swollen abdomen with ascites and lower extremity edema. You want to very carefully examine the neck because the jugular venous pressure should not be increased in cirrhosis of the liver. If you see someone you think has liver disease, but the JVP is elevated, that patient may actually have constrictive pericarditis. Pulsus paradoxus is rarely seen in constrictive pericarditis. Only about 20% of patients have pulsus. The reasons for this are unclear. All of the pressures in the heart are elevated, just like in tamponade. You can also see equalization of pressures, just like in tamponade. And there is a clinical finding on auscultation of the heart that is rarely heard. It's called a pericardial knock. It's a diastolic heart sound just after S2. It can often sound a lot like an S3. Kussmaul's sign is a classic finding in pericardial constriction. So when you take in a breath, as we talked about before, that raises the venous return to the right heart. And normally there is a slight fall in the mean jugular venous pressure. And you can actually see this if you examine the neck of normal patients. You can see the jugular venous pressure fall when they take in a breath of air. Kussmaul's sign is when the opposite occurs. The jugular venous pressure rises with inspiration. This is abnormal. And this happens in pericardial constriction because the ventricle cannot accept the increase in venous return. The right ventricle is surrounded by a calcified sac and it can't expand to accept the venous return. So instead, the pressure in the right atrium rises, and you can see that when you examine the neck. This is seen in constrictive pericarditis. It's also seen in restrictive cardiomyopathy, and you can rarely see this in a right ventricular myocardial infarction. It is not seen in cardiac tamponade. When I was a medical student, I had a lot of trouble keeping pulsus paradoxus and Kussmaul's sign straight, so I've got some tips for that in this slide. Pulsus paradoxus is the classic sign of tamponade, and you can remember that you see a pulsus in tamponade. The P is for pulsus. Kussmaul's sign is the classic sign of pericardial constriction. It's also seen in restrictive heart disease, so you can remember that you see Kussmaul's sign in constriction restriction. And I've made a table on the bottom of the screen summarizing pulsus and Kussmaul's. You see pulsus in tamponade, but usually not in constriction or restriction. You see Kussmaul's in constriction and restriction, but usually not in tamponade. There's a classic venous pressure tracing finding in constrictive pericarditis. It's called a rapid or prominent Y descent. Remember that the Y descent is the fall in pressure after the V wave. It's caused by filling of the right ventricle. In patients who have constrictive pericarditis, this becomes very rapid and prominent. It looks like this, and there are two reasons for this. So let's imagine that we have a right ventricle, and then we've got the tricuspid valve, and then above the right ventricle, we have the right atrium. In diastole, the right ventricular walls move outward. This draws blood in from the right atrium, and that causes the Y descent. Well, in pericardial constriction, the walls of the right ventricle are stuck and adherent to the pericardium. So in diastole, they snap very rapidly outwards, and this causes the Y descent to be very deep and sudden and abrupt. Then suddenly the right ventricle cannot fill anymore because there's a constriction surrounding it due to that calcified pericardium. This makes the pressure in the right atrium suddenly go right back up, and the result is that you get a prominent Y descent. And I've summarized these points here. There's rapid filling of the right ventricle with an abrupt stop and filling. The myocardium of the right ventricle is adherent to the pericardium, so in diastole there's rapid relaxation and suction of RA volume. This causes the Y descent to be very prominent or rapid. On this slide, I've summarized some of the key venous pressure findings in patients with pericardial disease. So in tamponade, the X descent is rapid and the Y descent is blunted or absent. In pericardial constriction, the major finding is a rapid or prominent Y descent. Another classic hemodynamic finding of constrictive pericarditis is called the dip and plateau or the square root sign. When you measure the pressure in the right ventricle of a normal patient, you see a tracing like what I've drawn on the screen here. So the pressure rises to a value of about 24 millimeters or so, and then it falls and comes up to a pressure at the end of diastole of about 5 millimeters or so. And this is what you see in a normal patient. In a patient with constrictive pericarditis, you see what I've shown on the right side of the screen here. So it has what's called the dip and plateau. You can see that there's a very deep dip here in the right ventricular pressure tracing, and then the pressure begins to rise but abruptly stops and then plateaus. This is also sometimes called the square root sign because it looks like a square root. And the physiology here is the same as the physiology we talked about before in the venous pressure tracing. There's rapid filling of the right ventricle because the myocardium is adherent to the pericardium. And then there's an abrupt stop in filling because there is a calcified pericardium surrounding the right ventricle. And this gives you the dip and plateau or the square root sign. I'll finish with this slide and mention that pericardial constriction and restrictive cardiomyopathy share many common features. And in clinical practice, telling the two conditions apart is very difficult. Luckily, they're both very rare. They're not going to ask you to tell them apart on the step 1 exam, but if you know that they share many common features, it's easy to recognize them in board questions. So both conditions have prominent right heart failure symptoms like jugular venous pressure elevation and lower extremity edema and dyspnea. You can see Kussmaul's sign in both conditions. You can see a rapid wide descent on the jugular venous pressure tracing in both conditions, and you can see a dip and plateau in the right ventricular pressure tracing. All of these are common to both pericardial constriction and restrictive heart disease. And that concludes our video on pericardial diseases.